obliged me in having joined this session to present cases from CMC. We are really happy. I'm just waiting for Professor Lakshmi Narasimhan.
Sir, you're able to hear us, sir?
Yeah, I'm able to hear you.
Okay, hi, sir. Okay, sir. Thanks.
I hope you are able to hear me as well.
Yes, my friend, sir. Hearing
okay,
well.
Thank you. Now, I said, I warmly welcome Professor Prabhakar, Professor Ajit, and Professor Vivek. Thank you very much for joining, and indeed grateful for you to have accepted and to present cases. I'm just waiting for Professor Lakshmi Narasimhan to join, otherwise we can start.
So this, yes, sir.
Just open line.
Sun team, is Professor Lakshmi Narasimhan joining?
Only 1%.
Hello. சொல்லுங்க பழனி. அப்படியா? அவர் அன்மியூட் பண்ணிட்டா ஆரம்பிச்சிடலாம். அவருக்காக தான் நான் வெயிட்டிங். சரிம்மா, அவர் சேர் பண்றாருல, அவர் அன்மியூட் ஆனாதான் சேர் பண்ண முடியும். சரி சரி, பாக்கி பேட்டு சரி ஓகே, பாக்கி பேட்டையும் சொல்லிடுங்க. நான் சொல்றேன். ஐம் ஜஸ்ட் வெயிட்டிங் ஃபார் ஹிம் டு ஜாயின் பண்ண ஆரம்பிச்சிடலாம்.
சார் கேக்குதா சார்?
Yes sir, very much
sir. And okay sir,
thank you very much.
Sir, sorry, I have been there.
No, correct. நானும் என்னாலயே என்ன அன்மியூட் பண்ண முடியல, அப்புறம் சொல்லி தான் அப்புறம் அன்மியூட் பண்ணேன். Anyway, it's very good that you joined.
Video இன்னும் அன்மியூட் பண்ண முடியல. It's okay sir, but at least audio.
We'll not waste time. We'll start on time.
Start the thing, sir. Thank you.
Yes, Lakshmi. Welcome all the delegates for another session of this Clinical Neurology Forum. And as I've already said, I warmly welcome Professor Prabhakar, Professor Ajit, and Professor Vivek Matthew. I'm very thankful to the entire CMC team and to the professors for having agreed to share their cases with us. And I'm very happy to say that we have Professor Lakshmi Narasimhan, the Director and Professor of Neurology at Sri Ramachandra Medical Institute and Research Institute. And I request him to take over the proceedings and conduct. Professor Ellen, please.
Good morning, everybody. And I straight away, on a lovely Sunday, wishing you all the very best for this lovely presentation. Over to Dr. Sarath Kumar for the PG resident to start the case. We will straight away get into the academics. Thank you.
Good morning, sir.
Good morning.
I'll be presenting the first case of the day. So we had a 46-year-old lady from Jharkhand, a known hypertensive. She had presented to us in March of this year with complaints of chronic persistent headache over a period of 1.5 years. And she then developed double vision with drooping of right eye. And she had weakness of left upper and lower limbs, which progressed over a period of 1 year. Along with that, she also had deviation of angle of mouth and diminution of hearing in the right side. Then over the last 6 months, she also had a change in her voice and swallowing difficulties. So elaborating the symptoms, the patient was apparently normal 1.5 years ago. Then when she started complaining of headaches, which was actually insidious in onset, progressive in nature, holocranial and dull aching type. And there were no associated features such as nausea, vomiting, or any associated visual disturbances at that time. 2 months later, after the onset of headache, the patient also complained of double vision. The images were separated obliquely for both near and distant objects. The family members also started noticing that there was drooping of her right eyelid, and within 5 days, there was complete closure of the right eyelid, after which the double vision subsided. So with these symptoms, the patient was evaluated in a local hospital And after their evaluation, the primary CNS tuberculosis was considered and the patient was started on anti-tubercular medications along with oral steroids. However, despite the treatment, the patient continued to develop progress. By June 2023, she developed weakness of her left side. She felt her limbs to be tight and she had difficulty in walking and doing fine activities with her left hand. The symptoms were initially subtle but progressed over the next few months. She required support to walk within her house. And over the last 3 months, she almost confined to her bed, getting up only for her toilet needs. And along with the onset of left-sided weakness, she also had diminution of hearing in her right ear. Same time, the family members also noticed that there was deviation of angle of mouth to the left with slurring of speech. Facial sensations were intact at that time. And since January 2024, there was a change in her voice with a nasal twang. She had swallowing difficulty, especially for liquids, with a sense of choking and nasal regurgitation while swallowing. And as the symptoms progressed, her food intake decreased, leading to significant weight loss. So there were no other symptoms such as tremors or involuntary movements. Her sensorium was preserved, no seizures, vomiting, or nausea. There were no history of altered bowel habits or bladder problems. Her memory was intact, language was good, no behavioral symptoms or psychosis. So this is her current functional status at the time of presentation. She was bedbound, partially dependent on others for her activities of daily living. She required assistance with transfers, dressing, and bathing. She was able to feed herself. She was able to indicate her bladder and bowel needs and communicate meaningfully. So the timeline, so October 2022, it started with headache, then with drooping of right eyelid and double vision in December. And in June, she developed left-sided weakness with hearing loss and facial weakness. And by December, she required support to walk. And by January 2024, she became bedbound. So summarizing her history, 46-year-old lady presented with insidious onset chronic progressive headache with multiple right-sided cranial nerve palsies, with left-sided spastic weakness, with intact sensory bladder bowel functions and preserved sensorium. And examination, her patient was conscious oriented with a GCS of 15/15. She had a flaccid dysarthria. Cranial nerve examination, the right side pupil was fixed and dilated, not reacting to light. Left side was reacting. And she had a complete ptosis in the right side. Her visual acuity was intact, like 6/6, with a normal fundus examination. Extraocular movements were mostly impaired in the right side, impaired adduction, elevation, and depression. No RAPD was seen, and vestibulo-ocular reflex was absent in the right side. And she was not able to frown in the right side, and the nasolabial fold was absent in the right side. Renis was negative, and Weber's was lateralized to the left on examination in the right ear. And tongue was flaccid with poor palatal movements and absent gag reflex. There was no atrophy or fasciculations. Motor system examination, there was a mild wasting of her left hand, calf, and quadriceps with a spastic weakness and motor power of 2/5, both upper and lower limbs. Reflexes were brisk and the plantar was upgoing. She also had a mild terminal neck stiffness. Her cranium and spine was normal. The other system examination, cardiovascular, respiratory, and abdominal examination was normal. So localizing her symptoms with a background of headache and other cranial nerve symptoms, such as drooping of right eyelid and examination revealing a third nerve palsy. We localized that either to the right cranial nerve, fascicle, or nerve. And deviation of angle of mouth to the left and examination confirming the same, we localized it to 7th nerve or nucleus. Right-sided hearing difficulty, examination revealed a sensory neural hearing pattern, localizing to 8th nerve or nucleus. And change in voice or swallowing difficulty, the flaccid tongue and poor palatal movements and absent gag reflex on examination, we localize it to the lower cranial nerves 9, 10, and 12. And left-sided weakness with spasticity on exaggerated reflexes on examination, we localized it to the right-sided pyramidal tract. So the localization of multiple cranial nerves and the long tract signs to the brainstem, and whether the symptoms were extraaxial or intraaxial. So the points favoring the extraaxial localization in our patient was like the headache with sequential involvement of unilateral cranial nerves, preserved sensorium, absent internuclear ophthalmoplegia. There were no dissociated facial sensations or Horner's syndrome. But the points favoring intraaxial localization was a cranial nerve involvement with the presence of long tracts, the pyramidal fiber involvement. So considering the history and examination and the temporal profile of our presentation, the differentials considered at the point was a CNS infection, tuberculosis, including multi-drug resistant tuberculosis, other infections such as melioid or listeria, and atypical fungal infections. CNS malignancies such as meningeal carcinomatosis, lymphomatosis, and secondary metastasis, and chronic inflammatory diseases such as IgG4 disease, neurobeshet, and sarcoid. Shall we go ahead to investigations?
Were the fourth and sixth cranial nerves preserved?
Yes, sir. Fourth and cranial nerve, sixth were preserved. Only third was impaired clinically, sir.
Okay.
Going ahead with the investigations. So we reviewed the imaging done in January. This was done in an outside hospital. Here we can see that there are some T2 flare axial images showing hyperintensities along the medial temporal lobe, along the midbrain in the crest, and the hyperintensities extending along the basal cisterns and the orbital apex. Periventricular white matter changes were also seen. And the contrast imaging also showed that there was some enhancement along the basal cisterns and along the tentorium of the right side, and the enhancement extending into the orbital apex. So with this imaging, she was started, a CSF analysis was also done, and she was started on anti-tubercular medicines with the oral steroids, considering CNS TB as a likelihood etiology. However, despite the treatment, she continued to progress, and the follow-up imaging done outside also showed worsening of her symptoms. This is a T2 flare imaging. We can see that the T2 hyperintensities have actually increased in size in the midbrain and even started involving the thalamus in the right side. And the medial temporal lobe hyperintensities were also increasing in size. And this is the contrast imaging also showing that the enhancement become more nodular, and there were some ring enhancing lesions also in the medial temporal lobe and in the thalamus.
Can I ask you for a minute?
Yes, sir.
Why did you choose tuberculosis as the first option? Mesial temporal lobe as a substrate for tuberculosis is a very, very rare possibility.
Yes, sir.
Generally, the emotions are not the first area to be involved. The limbic is not the first area to be involved in tuberculosis. What is your comments on that?
Yes, sir. We also had an open mind while evaluating. This is the presentation with which she was treated outside, sir, as a CNS TB. Here we were considering even other etiologies like.
Go on. I just wanted to say that mesial temporal lobe involvement is not very common, very, very uncommon in CNS tuberculosis. That's what the point I want to drive. Thank you.
Yes, sir. So the present scan done in our hospital, it showed that the worsening of the T2 hyperintensities, the flare axial showing the T2 hyperintensities have extended craniocaudally into the medial temporal lobe and midbrain thalamus. And we can also see that there is some edema significant with dilatation of the ventricles causing resulting in seepage of the CSF around the periventricular area. This is the T2 axial section showing the same. We can see that the hyperintensities along the basal cisterns are also increased in size. And there is some hypodensities within the hyperintensity suggestive of cystic changes. And post-contrast same, post-contrast scan showing irregular thickening along the parenchymal lesions. And also we can see that the pachymeningeal along the right tentorium and the orbital apex being thickened. This enhancement also extends into the internal auditory canal and also into the Meckel's cave. The parenchymal lesions also showed some patchy diffusion restrictions in the areas of enhancement, as seen in the DWI and the ADC images. And the MR spectroscopy actually showed a lipid lactate peak with choline being elevated, suggestive of neuronal damage. And MR perfusion showed elevated perfusion along the meningeal enhancement. And our blood and CSF workup, the routine investigations were normal, including even the immune and the vasculitic workup. Serum ACE levels was 18 and IgG4 levels were also normal. The infective screen, such as like brucella and cysticercal antigen, were also negative. CSF analysis showed mildly elevated cells, and protein of 143, glucose of 52. And the cultures, and including bacterial, fungal, were negative. Expert TB and MGIT were also negative for TB. The whole body PET scan, it actually showed a increased metabolism in the and enhancing solid cystic lesion in the thalamocapsular peduncular region, suggestive of a high-grade lesion. There was a high uptake with the SUV of 18.6. There were no other lesions elsewhere in the body. So summarizing the clinical radiological findings, presentation, progressive right-sided weakness with left hemiparesis. Imaging showed hyperintensities with solid cystic lesions with nodular ring enhancing lesions and patchy restricted diffusions, increased perfusion and ventricular dilatation. There was craniocaudal extension of these lesions, and along with meningeal enhancement, especially in the right tentorium, petrous bone, internal auditory canal, and Meckel's scale. So as we are not able to come to a conclusion based on the imaging and the clinical presentation and aspects of response to the tubercular therapy, neurosurgery consultation was sought and the patient was taken up for stereotactic brain biopsy. So the stereotactic brain biopsy, the fresh smears actually showed presence of epithelial cells with necrotic material within, and the H&E stain showed a nervous tissue with infiltration of the squamous cells. And the immunohistochemistry for P40 was positive, like highly specific for squamous cells. So the biopsy from the right medial temporum and the centrum revealed a diagnosis of like metastatic squamous cell carcinoma. So the radiotherapy team was consulted and the patient was started on palliative whole brain radiotherapy. And she was asked to follow up for a evaluation of probable primary and planned palliative systemic therapy by the medical oncology team.
So, Dr. Sarat?
Yes, sir.
Vivek here. So we'll stop and take opinions from the chair and as well as from Dr. Natarajan sir. Dr. Lakshmi sir, what do you think about this till now?
Yeah, the interesting thing was the moment you see a diffusion restriction, the partial or total diffusion means it is highly cellular. And we have always seen that the lipid lactate peak, the false positive lipid lactate peaks, we have seen quite often in many cases. So I think I was just wondering where could be the primary of the squamous cell carcinoma, if at all.
Yes, sir, that's a very good question. We'll come back to that. That's the next slide that Sarat will be presenting. But before that, sir, there were some questions on could it be melioid? Somebody has asked this question.
Yeah. In the chat box, I saw one question in the chat box.
Yes, sir.
Yeah, from Karthik.
Karthik, yes, and Karthik.
So when going in for the biopsy, one of the considerations was infection as well, even though radiology was more keen on malignancy. But for us, something which is going on for such a long time, the only thing against melioidosis probably is the long duration. So can melioid go on for so long? Usually we see that they go down in a few months. This is almost more than a year the patient has been symptomatic. The second thing was about conditions like fungal infections. Some unusual fungal infections also.
Right.
The patient had been on ATT and gradually progressing, and radiologically all that we had was a disease which is involving the meninges as well as the parenchyma, having cystic involvement within the parenchyma with enhancement, and it was kind of contiguous. Can you show the images, Sarat? Go back to that enhancement part. Yeah. Yeah, this one. Yeah, so you can see that in the coronal images also. It's all contiguous. So that contiguous part would very rightly raise the possibility of a melioid. But being a little bit more aggressive, it was an infection versus malignancy when we went in for a stereotactic biopsy. So we were also we didn't expect a squamous cell carcinoma amongst the. This was obviously not a meningeal carcinomatosis per se, because there is so much significant involvement of the parenchyma. And the second thing was that the CSF was relatively bland. It was not a very highly cellular CSF. So carcinomatous meningitis with low CSF glucose usually does not survive so long. The median survival is said to be about a month or so. So we were surprised to find squamous cell carcinoma in the stereotactic biopsy. And Sarad will now take you through what happened next. What we were
Ajit,
Ajit is yes.
I was thinking of a fungal involvement only. I was thinking of a fungal infection. It's going on protracted 1.5 years, but no response to tuberculosis medications. And the imaging appearance, I thought it could be fungal.
Yes, sir. That's precisely what Vivek sir just mentioned, sir, that infection versus malignancy were the main differentials.
Oh, yeah, I got it. Yeah. I followed your discussion, but
we had taken
sorry?
cultures of the biopsy. All the cultures were negative, sir, including bacterial and for fungal, and all the cultures were negative, and the biopsy was like a squamous cell carcinoma
with the markers.
Yes, sir. Keratin was positive. Yes.
Beta D glucan?
We didn't do that in the CSF. We didn't do that, sir.
Okay.
Yes, sir.
But we had from the biopsy specimen, we sent all the that's routinely the same, because fungal was one of the high up on the list of possibilities. Sarad, carry on.
Yes, sir.
What made you think? What made you go for PET scan?
Okay, sir. So here, when we have any other focus for infection, inflammation, or malignancy, since the considerations were any lymphadenopathy, any other foci of infection, which from where any other foci for tuberculosis. Finally, by the time that this had come, the PET CT was to look, since it is a squamous cell in the brain, it was as an unknown primary. To look for the primary, also the PET CT was required. Anything else on your mind, sir?
No, secondly, now did you look for the primary before that ultrasound abdomen or any other sort of X-ray chest which are shown features of?
Nothing, sir. She had there was no. Sarah, can you answer that?
Clinically, there was no systemic involvement at all, sir. Like sensorium was also good, and there were only CNS symptoms and signs, sir.
Because no, we never go for PET CT and stereotactic biopsy and all those things. Of course, the multiple cystic lesions in an odd place like this will make. We have had a few cases of melioidosis, where you have a few cases like that. So I thought that I was surprised when you thought of PET CT and you thought of secondary results. That's very good, actually.
Please continue.
Yes, sir. Thank you. So, coming to the brain metastatic tumors, this is the most common CNS neoplasm. Adenocarcinoma accounting for 60 to 75% of the metastasis, and squamous cell carcinoma about 10 to 20%. Population-based studies showed an incidence of 8 to 14 per 1 lakh population. The most common neoplasms that's metastasized to brain, as shown in the pie chart, lung, breast, and melanoma, and followed by others. And about in 2.18% of the patients, the primary carcinoma remains undetected, detected only as autopsy. So the interval between the diagnosis of primary tumor and the CNS metastasis is usually less than 1 year for lung cancers and can be multiple years for like other cancers such as breast or melanoma. But apart from this, there is another entity called primary intracranial squamous cell carcinoma. Though extremely rare, they can commonly manifest as a malignant transformation of intracranial epidermoid cyst. And very rarely, this squamous cell tumor can also arise de novo, and only few cases have been reported till date in the literature. This primary squamous cell carcinoma of the brain usually have a fibrous capsule that demarcates the tumor from the surrounding tissue, and they can be excised easily if diagnosed early. Coming to our case, there were no definite primary based identified on PET or systemic examination. The MRI showed features of solid cystic lesions with varying degree of enhancement, and there was leptomeningeal and parenchymal lesions with foci of diffusion restriction. So the possibility of epidermoid cyst with malignant transformation over the years was considered most likely. So the current imaging findings were also masked due to the late presentation and progression of the primary. Maybe the open biopsy would have clinched the diagnosis of primary CNS squamous cell carcinoma. And this is seen in the February scan. Only in the CP ankle we can see a solid cystic lesion.
There's a diffusion restriction. That's
Yes,
a image which is showing diffusion restriction in the CP angle.
So concluding a systemic approach to the clinico-radiological findings with histomorphological diagnosis whenever possible will help in early detection of brain lesions, increasing the survival of patients, even in primary brain neoplasms or metastatic brain lesions.
Thank you.
Even
Thank you for a wonderful case.
even the CP angle lesion may be secondary also, because
Yes,
even in the previous PET scan also, CP angle lesion was not found. So it has been found little later also.
yes.
And CP angle epidermoid, we see several cases. Going in for secondaries like this is extremely rare.
Yes, sir.
So the primary epidermoid cyst of CP angle can be ruled out.
Did you do a liquid biopsy, Dr. Sarath?
No, sir. Only stereotactic biopsy was done.
No, the liquid biopsy, the advantage of detecting a circulating tumor cells using a liquid phase biopsy is normally the CNS mets, no, the primary which is confined only to the CNS, or is it arising from somewhere else? This point you can differentiate by using a liquid phase biopsy. To see a circulating tumor cell in the systemic circulation, you have to be all out to search for a primary down below anywhere.
Yes, sir.
So in cases where we are not able to find a primary, the next step usually we go for a liquid phase biopsy where you look for a circulating tumor cell and to try to characterize that circulating tumor cell to whether it gives you a clue towards any de novo primary which is missed in a PET. Sometimes the primary may be very less avid for FDG. Okay. But whereas the mets can have a avidity, increased avidity for these things, we have seen quite often, where the primary is very indolent, doesn't even pick up doesn't light up on the PET. Whereas all the mets take up avidly the FDG. So that's also a possible. I just wanted to share with that liquid biopsy is also a good option to differentiate whether the tumor gives a clue where the primary is.
Thank you, sir.
Ellen, sorry, I didn't get it. What do you mean by liquid biopsy?
So liquid biopsy is from the fluids, sir, either from the blood. You take and then centrifuge it and look for circulating tumor cells when the primary is not known. Yeah,
that we usually CSF also we look for malignant cells, isn't it? Is it? Is it the same or?
No, this is a Japanese technique, sir. This is called a liquid or fluid phase biopsy, where any system, any biological fluid you can take, sir.
Yeah,
But
you can centrifuge it and
blood. So
yeah, you centrifuge it and look for atypical cells.
Circulating tumor cell characters, and even do a genetic on an oncogenes. They do a genetic also on the oncogenes to find out what is the circulating tumor cell they come from.
That is once you find some tumor cells. Am I right?
No, sir. No. What I'm saying is, when you are not able to find out where is the primary, you go for a liquid biopsy, look for any circulating tumor cells in the blood. Because you've already seen a metastasis. Hope I'm making myself clear, sir.
Yeah. I've not heard of it. That's why I was puzzled.
So once you see a metastasis in some part, not able to identify the primary, liquid biopsy is otherwise called the fluid phase biopsy, helps in identifying a circulating tumor cell, which they have a special centrifugal technique where the tumor cells settle at the bottom. They isolate it. They look for the characteristics, including a genetic oncogene analysis of the cells, and try to point out where the primary could be, so that you will go in depth in those areas to find out whether there is any quite a useful technique, sir.
Okay, thank you. That's the information. Yes, thank you.
Sir, thank you, sir. I think we can move on to the next case.
Sure.
Does Vivek have anything to say?
Yes, just one point that we never considered that there could be a primary or that it could have been a local invasion from malignant transformation of the epidermoid, because we also know that the epidermoids are majority benign or cause only local symptoms. We were surprised to find literature on that. So then when we looked at our own images that we had, because she was just recently admitted with us, we did not find anything in the CT angle. It was review. It was actually Dr. Aditya who looked back at the old images which we had scanned in, and that's what Sarath had put up. That February last year, that scan, when the lesion was not yet so expansile, at that time in the CP angle on the right side, sure enough, there was an area of diffusion restriction. At that time, it was considered to be a part of the entire process. But now looking back, we don't have a proof for it. We were just wondering, because there are case reports which mention this. And since we do not have a definitive primary. So that was the only reason. The unusual point was, and this is completely open for discussion. So that's just why we brought up. Thank you all for your inputs. We can move on to the next.
Thank you. Highly informative and interesting case. Thank you.
Thank you, Vivek. Thank you for a wonderful case. We move on to the next case when 7 helped 1 to overcome. You know, this number 7 is of lot of spiritual significance, starting from Saptarishi, not only in Hindu religion, in Islam, Hinduism, Buddhism, everywhere the sanctity of 7 is there. We look forward to an interesting case, how 7 helped to even the God had created 6 days and 1 resting day. That's what basically on this lot of interesting things on number 7. Go ahead with your case, Dr. Leslie Punraj.
Good morning to all. I'll be presenting the second case for today's discussion. It's a story of a 19-year-old boy from Jharkhand. He has presented with bilateral painless visual difficulty, progressive walking difficulty due to imbalance, and drooping of both eyelids over 2 weeks. He has a background history of childhood onset seizures and tremors of the left upper limb. His symptoms began during an exam time, when during the first 2 exams when he was writing, he had difficulty in seeing the words very clearly, but was still able to complete the exam. Things were progressive. By the third exam, he had to leave the hall midway because he could not see things well. Over the next 3 to 4 days, he had a feeling of imbalance while walking, and he needed increasingly more support to walk. There was no tripling, buckling, slippage of footwear, or any upper limb involvement. He also had slurring of speech and drooping of both eyelids. He was admitted to a hospital elsewhere and had received treatment with methylprednisolone 1 gram OD for 3 days, but there was no benefit with treatment and had therefore come to us. He has a past medical history. At the age of 15 years, had 2 episodes of GTCS of unknown onset. And at the age of 16 years, he had excessive jerky movements of the left hand. He had seizures and gait difficulty. Symptoms had lasted for a week and had slowly improved thereafter. He was a preterm child, but he had achieved normal developmental milestones on par with his younger sister and had good scholastic performance and was doing a bachelor's in computer science course. He was born to non-consanguineous parents. He had a younger sibling who was a stillbirth at term and a younger sister who was otherwise well. His father had right upper limb postural tremors and hearing loss since 25 years of age, and both paternal uncle and aunt had similar hearing loss at a similar age as well. His paternal grandfather had hearing loss around 40 years of age. On examination, his vital signs were stable. He was alert and awake. His visual acuity was 6/12 in the right eye, 6/9 in the left eye. He had features of optic ataxia and simultagnosia on examination. Extraocular movements, there was a slight grace preference to the right side, and he had bilateral restricted abduction. He had ptosis and upper face weakness and a nasal twang of voice. Power examination was normal, but the deep tendon reflexes were brisk. He had a normal sensory exam, and he had impaired tandem gait on examination as well. So in summary, it's a 17-year-old boy from Bihar with painless bilateral visual difficulty, progressive walking difficulty due to imbalance, drooping of eyelids which have occurred over 2 weeks, with a background history of childhood onset seizures and tremors of the left upper limb, with optic ataxia, simultagnosia, bilateral ptosis and restricted eye movements, mild facial movements, and brisk deep tendon reflexes bilaterally, with a poor response to hydrocorticosteroids received elsewhere. Looking at the localization, looking at the symptom cluster first of the visual symptoms, with signs of optic ataxia, simultagnosia with a normal fundus and no RAPD, the localization was to the posterior visual pathway along the dorsal stream. Walking difficulty due to imbalance with normal power, normal sensory exam, and cerebellar signs. The localization was to the cerebellum and its connections. Drooping of both eyelids, facial weakness, slurred speech, nasal twang of voice, with long tract signs and ophthalmoplegia. The localization was to the brainstem, intraaxial, and the history of seizures being localized to the cortex. So this was the differential diagnosis we had formulated of neurometabolic disorders like MELAS, MERF, SANDO, and Leys disease, organic acidurias, porphyria, Golgi-related disorders, and thiamine transporter-related disorders, CNS small vessel vasculopathies, inflammatory disorders, either a primary CNS angiitis or a systemic immune disorder with CNS manifestations, and leukodystrophies. This was the imaging at the time of admission. These are T2 axial images, flare axial images of the brain, which shows in bilateral caudate and putamen, there are T2 flare hyperintensities. Globus pallidus appears to be spared. There is involvement of bilateral thalami and the cortices, both along the frontal, parietal, and the occipital cortices. This is the T1 axial images of the brain, which shows in the corresponding areas there is T1 hypo. This is the diffusion axial images, which is showing areas of diffusion restrictions along both in the deep gray, thalami, and also along the cortices. This is a post-contrast imaging of the brain, which is showing occasional areas of contrast enhancement, but not much. These were his investigations.
And any comments, sir? Lakshmi sir, VN sir, any comments, sir?
Others are also, it's open to everybody.
Yeah.
Everybody can comment.
It's open on any other, just go back to the previous. Any comments on the image, anybody? The bilateral symmetrical involvement of the
Gray matter.
The deep gray matter nucleus, and in fact the gyrus also looked slightly edematous and thickened. Gyriform pattern of
Yes.
is there, and can you show me that? Did you do a SWA?
Yes, sir.
Is there anything significant on the SWA?
So do I,
No, sir.
no, sir.
Susceptibly weighted imaging, anything was there?
No, sir. No,
No, sir.
no, sir. There is no blooming.
Okay, fine. So why did you think of Paul G? What made you think of Paul G related? Is it the ophthalmoplegia which?
Yes, sir.
With cerebral.
Ophthalmoplegia, previous history of some tremors, or family history of tremors also was there, sir.
Okay, thank you. The family history. Okay, fine. Go ahead, continue.
Family history was more of hearing deficit, isn't it?
Yes, sir. Yes, sir. Hearing loss in the family.
Under postural tremor, no? Right
Yes,
side.
sir. In the father, yes.
One member of the family.
These are the investigations. There was mild macrocytosis noted. CBC was normal. Liver function, renal functions, and electrolytes were normal. Lactate, CK, and ammonia levels were normal. Urine organic acids, urine amino acids, and serum amino acids were normal. Bloodborne virus screening was negative. CSF exam was normal, including tests for viral multiplex PCR and routine bacterial cultures. Immune workup with ANA, dsDNA, SSA, SSB, and CAS were negative. So the differentials considered here was infective versus inflammatory versus neurometabolic. Infective workup was negative. He has received good dose of immunomodulation elsewhere with no improvement. And he was started on an empirical treatment of some drugs. I will come to the details of which later. We have not given any further immunomodulation with IVIG or plasma exchange.
Does the symmetrical MRI appearance, does it give any clue? It's almost exactly the same on either hemisphere. It's very symmetrical. Does it give a clue? Is it more in favor of a metabolic?
Yes, sir. More in favor of a systemic neurometabolic, yes.
And mitochondrial also, no? Mitochondria also has some symmetry.
Including, yes. Particularly the hearing loss in the family members may be a clue. Proceed, sir.
And lo and behold, with this treatment that we had given, his ophthalmoplegia, optic ataxia, simultagnosia improved within a few days of starting these drugs. He was followed up at 4 months, and those medications were continued, and all symptoms had improved except a mild left hand myoclonic tremor. So what do you think the diagnosis is?
Some nutritional factors.
Simon?
Slide with the image.
Chitramalam has something to offer. Chitramalam, thiamine, is it?
Yes.
Yes, sir.
Any thiamine, sir?
Yes, sir.
Yes, sir.
So the genetic testing that we had sent in retrospect after 3 months had come, which showed a mutation positive, a homozygous missense mutation, positive for the SLC19A3 gene, and it was likely pathogenic. So the final diagnosis was biotin thiamine responsive basal ganglia disease. This is his imaging at follow-up, which shows stark resolution of all his lesions.
Leslie, once just show the medgenome report. Okay. So likely pathogenic.
Yes, sir.
Consanguineous parents, correct. Right. Yes.
No, sir, not consanguineous.
So parents are not non-consanguineous, sir.
Okay, right.
This is the imaging done at follow-up, which has showed that the lesions had cleared up. And the treatment that we had given was high-dose biotin. Now, biotin, we have only 5 mg tablets. We had to give him 20 tablets thrice daily. And we had sequentially increased it to 150 mg thrice daily. Thiamine, levetiracetam, and clonazepam. And the mitochondrial cocktail was initially given. But once the genetics were confirmed, we had removed the mitochondrial cocktail and continued only the first 4. Short discussion on biotin thiamine responsive basal ganglia disease. The gene responsible is SLC19A3. It codes for the thiamine transporter type 2. This is expressed on the mucosal surfaces of the small bowel, and it helps in the absorption of thiamine. Now, thiamine gets converted into thiamine pyrophosphate, which is its active form. Now, this active form of thiamine is a cofactor for some of the enzymes, and one of the integral enzymes there is pyruvate dehydrogenase complex. Now, this enzyme is the one which converts pyruvate to acetyl-CoA. Acetyl-CoA gets shunted into the mitochondrion to take part in the Krebs cycle and produce energy. In the absence of thiamine pyrophosphate, and especially in times of stress, metabolic stress, where this needs to be upregulated, patients who have a mutation in this gene cannot upregulate the thiamine transport, and therefore they have an energy deficit problem. So there appears to be a metabolic block in the absence of thiamine pyrophosphate. Now, how does biotin help in this? Biotin helps in shunting the pyruvate directly into oxaloacetate. Now, the Krebs cycle is interesting because the Krebs cycle will keep continuing to run, not only in the presence of acetyl-CoA, but then even if one of the downstream metabolites of that, if it is available, the cycle will keep continuing to run. So although acetyl-CoA is not formed, biotin converts pyruvate directly into oxaloacetate and keeps running the Krebs cycle and produces the necessary energy. That's how biotin helps thiamine in this process. Looking at the clinical presentations of biotin thiamine responsive basal ganglia disease, there are three forms. The most deadly form is the early infantile form. They present as a rapid progressive encephalopathy, seizures, lactic acidosis, and neuroregression. It has very poor response to thiamine and there result in premature death. This is the most severe form. Second is the early childhood encephalopathy, in which along with the encephalopathy and neuroregression, there can be seizures, spasticity, dystonia, gait and behavioral abnormalities. There is partial response to thiamine in this as well. In our patient presented with something like a Wernicke's encephalopathy, and this is called the late onset Wernicke's like encephalopathy presentation, in which there is acute onset neurological and encephalopathy, seizures, nystagmus, ophthalmoplegia, and ataxia. And there is good reversal of these symptoms with high dose thiamine and biotin supplementation. What are the imaging clues for biotin thiamine responsive basal ganglia disease? There are bilateral symmetrical lesions in the caudate, putamen, and medial thalamus, and there can be variable extension to the brainstem, cerebral cortex, and cerebellum. The globus pallidus is typically spared. In the acute setting, in the time of crisis, there can be diffusion restriction as well. There is sparing of mammillary bodies, and there is extensive cortical involvement in this genetic forms of thiamine transporter deficiency as against acquired forms of Wernicke's encephalopathy in which mammillary bodies are involved and there is not much of cortical involvement. And there is absence of significant contrast enhancement in this. So management, we need to understand that this is one of the very treatable metabolic disorders. In the time of crisis, patients would need ICU support, maintenance of ventilation, treatment of seizures, empirical antibiotics because infections usually trigger crisis, and anti-dystonia measures. Aggressive control of fever must be done because fever downregulates SLC 19A3 expression. Biotin is initiated at higher doses than the mitochondrial and the biotinase deficiency groups. And thiamine also is replaced at 10 to 40 mg per kg. Treatment for this with biotin and thiamine is lifelong, and we need to avoid drugs that meddle with the thiamine metabolism. Prognosis for early childhood phenotype, there is some clinical improvement and even remission with biotin and thiamine. The missense variations, as in our patient, have very good response as against the frame shift variations or deletions, which have a poorer prognosis. As for the sequelae, half of these patients have some cognitive sequelae and poor visual motor integration. This is one of our in-house, one of the first cases published in our country. This is published by Dr. Karthik sir and his team, and in which they had described a 12-year-old girl with generalized dystonia and seizures since 5 years of age with ataxia, who had presented with a status epilepticus, very similar imaging finding to us, and very good response to treatment. And in-house, we could prove the same genetic mutation and similar variants also being identified in the sibling and father. The differential diagnosis for the basal ganglia lesions in this case, Broadly, we can classify them into the lesions which affect predominantly the choroid and putamen versus globus pallidus. This is not very strict because there are some diseases like carbon monoxide poisoning, methemoglobinemia, wherein this pattern can be different. We also look at the T1, T2 combinations of being involved and whether apart from the basal ganglia, there are other typical sites being involved which can give us clue about the etiology. So in globus pallidus, T2 hyperintensity predominantly being there, these are the list of diseases in which this can be seen. Succinic semialdehyde dehydrogenase deficiency, methylmalonic acidemia, isovaleric acidemia, PDH deficiency, GAMT deficiency, and carbon monoxide poisoning. Now, along with T2 hyperintensities, if there are some other sites which are being involved, like in Kearns-Sayre syndrome, there is involvement of the subcortex and of the dentate. This very similar pattern is also seen in L2 hydroxyl glutaric aciduria. If along with T2 hyperintensities, we are also seeing involvement of the peri-Rolandic region and of the insula, we can think about urea cycle disorders. Now, diseases which predominantly affect the caudate and putamen and relatively spares globus pallidus. These are the list of Leigh disease, thiamine transporter deficiencies, glutaric acid, propanic acidemia, Wilson's, Huntington's, molybdenum cofactor and isolated sulfite oxide deficiency, HIE and hypoglycemia. These are the list in that category. Looking at basal ganglia T1 hyper, the list includes HIE, carbon monoxide toxicity, manganese, methemoglobinemia, and liver failure. Some of these can have diffusion changes as well, as in infarctions, HIE, carbon monoxide toxicity, mitochondrial diseases, basal ganglia, biotin thiamine responsive basal ganglia disease, some encephalitis, and Wilson's. So the take-home message is it's a treatable metabolic disorder. We need to think about biotin thiamine responsive basal ganglia disease when we see a typical history of seizures and a Wernicke's disease-like presentation with the typical classical imaging features, and it responds to high doses of biotin and thiamine. Thank you.
Thank you, Leslie. Vivek here. I must say that it's credit to the team for a boy who came to the casualty, Angel, Aditya, and Ajit, and Prabhakar, who insisted on treating him as metabolic first and showed within the next few days that he started improving. And then subsequently the report came positive. Leslie, why did you call it 7-1?
So biotin is vitamin 7, B7, and thiamine is vitamin B1. So biotin has helped thiamine overcome the metabolic block here.
Either pure biotin
ETK activity regularly.
Sorry, sir.
The erythrocytic transcutaneous, do you do regularly?
No, sir. We don't do ETK here.
In fact, ETK is one of the very good marker for the assess the thiamine status. Pretty early, even before you go to the genetics. Any issues, whether it is thiamine monophosphate or thiamine diphosphate or thiamine triple phosphate, all the three, anything. If you want to really know about the thiamine status in any, whether it is the Wernicke's form or the non-Wernicke's form, the ETK would definitely help you to identify that. And is quite interesting is the sparing of mammillary bodies and the any idea why it has been like that? Did you look into the literature why it is? Why the Wernicke's picks up that and why this doesn't pick up? Anything? Anybody? I don't know, but I just thought it was quite interesting to see why a particular areas are spared in.
Yes, sir. We didn't think of that. We'll look at it, sir. Certainly.
Sure. Thank you. Thank you. Wonderful case, and I'm sure that every one of the attending here would agree that it was an intellectual feast of the basal ganglia imaging. I really thank. I'm sure that all the postgraduates who attended this would be enormously benefited by a beautiful summary of the basal ganglia imaging. Thank you so much for Dr. Leslie Ponraj, and thank you for Vivek, Matthew, and the entire team, Ajit and Prabhakar. Thank you.
Sir, we had a case of 5-year-old child with genetically proved thiamine deficiency disorders.
Yes, Jamalam. Yeah, tell me.
Yes, sir. Yes, sir. We had a child presenting with unresponsiveness, episodes of hyperventilation unresponsiveness, and the genetic workup was in favor of time and metabolic disorder, sir. So the follow-up is not there.
I think
Child presented with seizures. Child presented with seizures. A 5-year-old child, sir.
last month Vishwanathan presented a case from Apollo, isn't it, with biotin deficiency.
Okay, sir. So the gene was a TPK1 gene, sir.
There's likely to
So
be
time
more.
and metabolism dysfunction syndrome 5, it was.
In Dr. Lima Pauline and Dr. Maya Thomas frequently, I think they have a large case series of most of the vitamin responsive syndromes, sir.
Okay, sir.
Both Dr. Professor Lima Pauline and Professor Maya Thomas, I've seen them presenting in few conferences of the vitamin responsive syndromes. They have got a quite large series, and a couple of them have been published also.
Yes, sir.
Ellen, Dr.
Yes,
Jayakumar of Madurai also has.
oh, no, I didn't.
Yes, yes.
So, in fact, sir, the one more important point which I just wanted, as you all of you know, that the riboflavin transporter deficiency, the cases mimic the juvenile MND, where the Violetto-Von the syndrome, Von Layer syndrome, and it is closely related to riboflavin transport deficiency, where in the institute we diagnosed about 3 cases of juvenile Madras motor neuron disease, turned out to be riboflavin transporter, supplementation of large dose of riboflavin. Patient walked away, wheelchair bound for 3 years. So absolutely. I think the vitamin responsive syndromes have opened up a new arena for treatment purposes, sir. And riboflavin, now the 100 milligram riboflavin has come to the market. So yes. Not necessarily to go for 10 tablets, 20 tablets, which will burden the patients. Thank you.
Just a small note on this. Initially, it was labeled as biotin responsive basal ganglia disease. But as they discovered, as Leslie mentioned, like once they discovered that actually is a thiamine metabolism which is a problem. And actually the biotin BRBGD was a misnomer. That's why the terminology was changed to biotin thiamine responsive basal ganglia disease. And biotin is just responsible for initially overcoming the metabolic block. It's actually thiamine which needs to be considered very long term. And whenever these children or adolescents come off thiamine, that's when they have the maximum chance of recurrence and going back into crisis.
Thank you, Ajit. Thank you, sir.
Thank you.
We have one more case, sir.
We have two more.
We have two more.
Okay, then we move on to the next.
2 more or 1 more?
2 more, sir.
2 more.
The next presentation will be by Dr. Gomati, sir.
Yes, please.
Good morning, sir.
To share your screen, I think Leslie has to unshare the screen.
Good morning, sir. Are my slides visible?
Yes, yeah. Please go ahead, Dr. Gomati.
Yes. Today we have 2 interesting patients of considered as an IIH, which were near misses on the OPD. The topic will be beyond what the eyes can see. First patient we have is a 38-year-old lady from Andhra Pradesh who presented with chief complaints of headache for 4 years with a recent worsening over past 3 months. So the patient presented with headache, which was for the initial 4 years was either holocranial headache or one-sided with a frequency of 2 to 3 per month with nausea, vomiting, photophobia, phonophobia, and subsided on analgesics. So it was suggestive of a migrainous type of headache. Now she had presented with a worsening and a change in pattern of her headache for the past 3 months, which was now daily continuous headache with starts in the orbital area, then became generalized over a period of 1 hour. She also noted that the headache worsened on standing and walking. It was also associated with blurring of vision. However, she did not have any history of visual obscurations, weight loss, fever, or other significant complaints. Her past history was significant only for a hemorrhoidectomy in the month of August, for which she also had a low hemoglobin and was transfused with 2 units of blood. On examination, she was found to be pale, and central nervous system examination was significant only for the presence of bilateral disc edema. So at the end of history and examination, we have a lady with an only significant headache with a worsening of 3 months and features of raised ICP on examination. So the possible differentials and localizations we consider were either to the meninges, to the CSF spaces, vascular causes, and slow-growing tumors. So we went ahead.
What was BP?
The BP was normal, sir. It was around 120/80. So we went ahead with further evaluation. So the first thing which we considered was a raised ICP with headache. So MRI was done. MRI was showing features of raised ICP in the form of tortuosity of the optic nerves bilaterally with a partially empty cella. And so considering no structural pathologies, we went ahead with a CSF analysis, which showed—
What was the MRI venogram? MR venogram.
Venogram was normal, sir. There was no evidence of thrombosis or
Constriction in the lateral sinus.
no, sir. She had only she had a normal MR venogram, sir.
Okay.
So we went ahead with the CSF analysis, which showed an opening pressure was very high, which is more than 50 centimeters of water, with normal cells, normal glucose and protein. So we thought of a probable idiopathic intracranial hypertension and went ahead with an ophthalmological evaluation. So as we can see, there is bilateral disc edema. The retinal nerve fiber layer thickness was done, which was found to be increased in all quadrants, and visual field also showed evidence of peripheral visual field constriction. As we were evaluating further, we noted that her CBC profile showed the presence of biocytopenia, a total count of 2,200 with a hemoglobin of 5.5, with no significant blasts on a peripheral smear. So we went ahead with the secondary markers such as iron profile, B12 assessment, which were essentially normal. So considering the biocytopenia with no other metabolic abnormalities, we went ahead with a bone marrow analysis for her. Both the bone marrow aspirate and biopsy were showing features of increased infiltrates of immature precursor cells around 40 to 50%, and blast percentage was about 53%, with positive markers for both the myeloid lineage. So her investigations were consistent with that of an acute myeloid leukemia. So we had 2 issues with her. So we had started her on acetazolamide for the headache with features of raised ICP. And for the AML, we had suggested for a treatment with chemotherapy, which she wished to do at a local hospital. We move on to the second patient. So she was a 45-year-old lady from Bangalore who presented with history of headache with visual symptoms of 5 years duration. This was the timeline of her history. So her headache initially started in 2017, where she was treated symptomatically. For the next 2 years, she was headache-free. By 2021, she noticed a recurrence of headache, evaluated locally, was diagnosed as IIH based on an MRI finding, and she was started on acetazolamide for 2 years, with which she had improvement. After which she stopped and again had a recurrence of visual symptoms from 2023. MRI again showed features of raised ICP. So this was the history she came in with: an intermittent headache with a postural variation, visual symptoms, and transient visual obscuration. Otherwise, she was also under hematology follow-up for an incidentally detected thrombocytosis and polycythemia. MPN panel done outside was negative and was started on aspirin prophylaxis for the same with an allopurinol for hyperuricemia. So when she came to us, it was for a second opinion. She was evaluated at Bangalore, and imaging was showing features of mild transverse sinus stenosis. Hence, they had suggested a transverse sinus stenting for her. So she came in for a probable definitive therapy for a probable refractory IIH. So we had again went on to ophthalmological evaluation, fundus showing disc edema, RNFL thickness being increased, and enlargement of the blind spot and peripheral constriction on the visual field analysis. Imaging done here again showed features of raised ICP. 3 out of the 4 cardinal features of MRI based on treatment criteria was there. There was a mild transverse sinus stenosis on the right side also. So initially, she had come to our OPD with features of raised ICP. So on further evaluation, because she had an underlying history of a thrombocytosis, we had sent her for an hematological evaluation for that. So the hematologist then noted that she also had a splenomegaly and hyperpigmentation over the skin. So the possibilities of were considered, and they had also done a nerve conduction study. So we suggested a nerve conduction study in which, because of she had mild sensory symptoms of 6-month duration of her lower limbs. So as we can see, the motor and sensory potentials were not obtained from the lower limbs, and upper limb showed prolongation of distal latencies from the median and ulnar nerve, suggesting a sensory and motor polyneuropathy demyelinating with a secondary axonal pattern. So go ahead with the treatment. So this was the blood reports. Her routine blood showed presence of a thrombocytosis, 0.9 lakh platelet count. The CSF pressure, which we repeated here, was 17, possibly because she was already on acetazolamide treatment. Normal cell count, but a protein of 105. So this was against a diagnosis of an IIH because the Dandy criteria says that the CSF has to be essentially normal with a normal protein level. So with the coexistent neuropathy, we went ahead with the neuropathy evaluation as well. Her blood sugars, B12 levels were normal. So electrophoresis was done, which was again normal. Benzone proteins were negative. Immunofixation electrophoresis revealed there was a faint IgA lambda chain, but a normal kappa-lambda ratio. Her VEGF assay was twice the normal of the upper limit of around 1431. So with the thrombocytosis and a VEGF being elevated and immunofixation showing an IgA lambda, we went ahead with a bone marrow evaluation for her, which showed hypercellular marrow with increase in megakaryocytes. So the secondary hematological malignancy panel, including the NGS and FISH, were negative. So we went ahead with the PET. So PET was consistent with features of splenomegaly, mild pleural effusion, and also showed sclerotic focuses in sternum and D12 vertebra. So as we can see, patient fit into the criteria for Poem syndrome. She had a demyelinating polyneuropathy with an IgA lambda chain, sclerotic bone lesions, VEGF elevation, splenomegaly, pleural effusion, hypothyroidism, hyperpigmentation, papilledema, as well as thrombocytosis. This was fitting into an acronym of POEMs called PEST: papilledema, extravascular volume overload, sclerotic lesions, and thrombocytosis. So this patient, who was initially treated for an IIH, who had come to us for a second opinion, on further evaluation and comprehensive assessment, was found that she had another essential disease which required prompt treatment. So based on literature review, we had treated her with only limited field radiation therapy because only 2 lesions were there in the sternum and the D12 vertebra. She received 25 fractions of 45 gray each till date. So as she was coming for a follow-up, after 3 months, she noted that she had worsening of the sensory symptoms and also had difficulty in walking. So hematology review was again sought for starting systemic therapy. However, they wanted to go ahead with the radiation and wait for a period of 3 to 6 months on follow-up to assess regarding that. So we had started her on empirically with methylprednisolone and mycophenolate for the sensory symptoms, with which she had improvement. She was continued on aspirin for the thrombocytosis, and raised ICP was managed with acetazolamide. So she improved symptomatically and also had a resolution of skin lesions on therapy. So shall we go on to the discussion, sir? So these 2 patients show us that intracranial hypertension cannot be benign. So not all raised ICP is equivalent to idiopathic intracranial hypertension. We know that we have to always evaluate for secondary causes of raised ICP, venous sinus thrombosis, anemia, obstructive sleep apnea, drug-related causes, antibiotic use, steroid use, vitamin A use, and other causes of meningitis, and endocrine causes as well, such as Addison's and hypothyroidism, before labeling as an IIH. Here are a few of the systemic conditions which can masquerade IIH. Hematological malignancies, as we mentioned, AML can be there, CML can also present. Infections, HIV, syphilis, Lyme's, mucor, autoimmune conditions such as Behçet's and SLE. Genetic causes have also been indirectly involved in causing IIH, so cystic fibrosis, Jitterman's, Turner's, and PTEN mutation, endocrine causes as well. So in our patient, how do we explain the raised ICP? Is that she did not have an increase in the lymphocytes, so that is unlikely to contribute. So one thing which we noted was contributory is because probably of the anemia. So anemia is around 18 to 22% of the patients who are diagnosed as IIH have a coexistent anemia. How it contributes is that the iron deficiency will lead to thrombosis by reducing the deformability of the red cells, and it increases the blood viscosity. Also, iron is essential for inhibiting thrombopoiesis. In the setting of an iron deficiency, there is thrombocytosis, again causing viscosity increase. It also leads to increase in venous pressure, decrease in the rate of CSF absorption at the level of the arachnoid villi. Also, because of decreased oxygen carrying capacity of blood, there can be a secondary cerebral hypoxia and cerebral edema. And also we know that anemia causes increase in cerebral blood volume. All these can indirectly contribute to raise in ICP. Apart from our patient, in others with hematological malignancies, there can be a direct leukemic infiltration of the optic nerve, but this is usually asymmetrical or unilateral, and papilledema can also be due to raised ICP. So the mechanisms by which it can be is because of directly in those with the leukocytosis, the elevated count can cause hyperviscosity, obstruction due to direct meningeal infiltration, venous sinus thrombosis, POEM syndrome, as in one of our patients. There is an increased vascular permeability, which is caused by VEGF and other cytokines, which also because of the increased CSF protein. All these can secondarily result in raised ICP. Therapy-related causes such as ATRA treatment for APML, wherein the retinoids will increase the CSF production and alters the lipid constituents of arachnoid villi. So summarizing, we have to know that caution has to be exercised before labeling patients with raised ICP and normal imaging as an idiopathic intracranial hypertension. Hence, a comprehensive evaluation of the patient as a whole for all systemic pathologies is important before labeling as IIH. And in those with consideration of hematological malignancies, importance should be given for raised ICP because it can be presenting as the initial feature. Thank you.
Thank you. Thank you for an excellent case. The topic is open for discussion. There's no chat questions.
Will contrast MRI contribute further in these cases, even before the entire diagnosis is made? Like the first case, you said that the MRI had only optic nerve features and empty cella with a normal venogram. Will a contrast MRI contribute a little more about enhancement of the meninges and so on?
Yes, sir. In case of chronic meningitis, which can be cause of the secondary increase in ICP, contrast MRI will definitely be helpful. Also, to look for possible thrombosis, also contrast will be essential.
So our protocol usually says our venogram is also most often, rather than a TOF, we do a dynamic MR venogram. So because of which contrast is given to all these patients. So we do an MRI brain routine sequences along with GADO and a dynamic venogram. So yeah, certainly a contrast would help. In this, the first patient who was found to have a leukemia, she had a CSF done, which was essentially normal. So she did not have a leukemic involvement of her leptomeninges. The second patient, so the first patient presented with a bicytopenia. Her hemoglobin and the total counts were low. The second patient presented with diagnosis of possible IH along with high hemoglobin and high platelets, so thrombocytosis and polycythemia. Both these patients went in different directions. So that was the thing to highlight over here, that when we are seeing patients who are not responding to who have some additional systemic problem, then because IH is such a broad pathophysiology, then there are so many things which can trigger the raised ICP and features suggestive of IH. For that reason, secondary causes need to be excluded whenever there is something unusual about the patient. The second patient does not fulfill the criteria for IH because of the CSF protein being elevated. It was 105. And in her case, while on acetylcholine, her CSF pressure was actually normal when it was done over here. So it's quite likely, and it is described as well, that in Poem syndrome, the patients have VEGF-related microvascular changes, and these can contribute to the disc edema as well. So this is just to point out some unusual things which lead us down a path in hematological conditions, both of these. So we have still one more patient, sir. Any more questions on this, sir?
So if patients are already on acetazolamide, how long can we stop acetazolamide to prove the criteria for IAH? CSF opening pressure. Can we stop it for 3 days, or how many days we can stop it before trying to prove that it is IAH criteria fulfilling CSF opening pressure?
Okay, sir. So ideally it would be about at least about 5 days, sir. That would have to stop because of the carbonic anhydrase mechanism. But truly speaking, if we have a patient who has headache, who has papilledema, and who has a normal MRI brain with GADO and VINO, then the CSF which we are doing from the point of view of the Dandy criteria, more than looking at the elevated CSF pressure, what we're trying to show that the CSF contents are normal. So there are some conditions which can mimic IH with all the above correct, but not having. So suppose a patient has got a headache, has got papilledema, has got a normal MRI brain other than the findings, Friedman's findings of raised ICP, and the CSF content is normal, even if the pressure, because the CSF manometry, how it is done, has its own nuances. We do it slightly differently, it can come falsely low. We do it slightly wrongly, it can come falsely elevated as well. So for that reason, it is a combination of all the things that are taken into account, and not on the basis of the CSF pressure alone. The one situation in which it becomes, two situations in which it becomes important is in those patients who we are dealing with, which we want to label as IH without papilledema. Over there, they are very strict on the CSF pressure. The CSF pressure has to be measured properly. And the second situation is in patients who have CSF rhinorrhea. So those who have so-called spontaneous CSF rhinorrhea, the decision on whether, along with the repair of the leak, of the CSF leak, along with that, do they need a definitive therapy like a ticoperennial shunt? That decision would be based on CSF pressure to a large extent, besides, of course, all the other findings. So these are two situations in which it becomes important. But for a patient with papilledema, more than the manometry, it's the contents that we're looking at and working up the secondary causes.
Yes, sir. Since you presented with IAH with hematological diseases, I just want to mention that you'll have to be cautious in patients with sickle cell disease. Acetazolamide is absolutely contraindicated in sickle cell. So we'll have to be a little cautious about that. Once initiated, it may trigger a sickling crisis.
Thank you. Thank you, Professor Chittambalam. Before we move on to the next stage, just a couple of points to add. One is this patient was referred for stenting. The Attico-MRV sequences, the Attico-MRV sequences with the combined conduit scoring is one of the important way to identify whether the patient is eligible for stenting one. This work was done by when Dr. Muthu was there in our institute. He did his work on Attico-MRV. Second, with this, we move on to the next case.
Excuse me, can I ask only a very basic question? still I'm not able to understand. This patient was having no leptomeningeal secondaries, and a patient was having leukemia and features of ICT. Ophthalmoplegia was there?
No, sir. So this is over here we are thinking that it is the anemia, the severe anemia, which is causing the papillary. That's what Dr. Gomati was trying to show, that that in the patients with severe anemia also we can have disc edema, papilledema. Whether we should call it an IH or a secondary IH or a secondary raised intracranial pressure. The point over here again is just that the when there is a systemic factor, like just like we have, for example, a high BMI. So we say that one of the treatments should be to reduce the BMI. Over here, we found an anemia. Workup for the anemia showed that it was actually anemia and leukopenia showed that she had a leukemia. So it is so the treatment goes for the things. Yes,
how do you explain ICT in this case?
How do you explain?
ICT.
Gomati, can you just go back to that slide? So these are all various hypotheses. So there's some in this was in several years, in 2003, more than 20 years back, the American Journal of Ophthalmology, this group, Valerie Bios, is still one of the major persons in IAH, and she is the one who is currently, along with Deborah Friedman, who are looking at IAH across various spectrum of IH. So Valerie Boyce, this is in 2003, she had published an article on anemia and papilledema. And what are the various, these are all of these are hypotheses, sir. So we don't know exactly how, but there is an association. How exactly it causes, we do not know. But this was the publication which Dr. Gomati was able to find, and we had put it up, sir. Does this kind of answer your question, sir?
Thank you, sir. Thank you, because still it is not very much completely known why it produced. And second is that, is there any other case which has been presented with ICT in a case of Poem syndrome?
Yes, sir. So papilledema, Gomati, can you go to the criteria for
Yes,
Poem?
sir.
So Poem syndrome, one of the minor criteria is papilledema. But this papilledema need not be raised ICP, unlike the first patient. Over here, the papilledema can also be due to the VEGF. So Poem syndrome, most often in neurology, we work up from a neuropathy and come to Poems. This was a patient where she presented with disc edema to begin with. She had developed mild sensory symptoms in the 6 months just prior to coming to us. And she and it was just we caught her while the neuropathy was progressing, whereas papilledema was the earliest thing. So in this list, if you see, she started with papilledema and thrombocytosis and polycythemia. The other things came on over a period of time, over a period of 3 to 4 years, and she worsened the neuropathy during while she was on treatment. So papilledema, disc edema is well described, and in fact is one of the criteria for diagnosis of Poem syndrome, sir.
Oh, thank you very much. Because in this era of MRI, we get several cases of surprising report as ICT, papilledema in MRI. Clinically, no history of headache or vomiting. So I think in case of, we should not ignore that type of MRI reports. That is the lesson which we have learned now. Thank you very much.
Yes, thank you, sir.
Dr. Arun Kumar in the chat box has said elevated CSF protein itself can cause papilledema like in CADP. Yes, information. And one more thing, which the optic nerve sheath diameter using the Doppler probe, where monitor the thing, and it's a very good measure. In fact, we monitor the. I think in your ICU also you'll be monitoring the optic nerve sheath diameter for reduction of the intracranial pressure non-invasively. Even a single dose makes a lot of change. I was surprised by that. Even a single dose reduces the optic nerve sheath diameter and see how your patient is responding or not. So that is another good way of monitoring the treatment when you're reducing the ICT. Thank you.
Yes.
We move on to
Yes.
the next case.
Thank you, sir.
Thank you, sir.
Good afternoon. We'll be coming to the last presentation for this session. I'll be
So
talking about it.
your slides are not on. Can you share your screen?
Is it coming now?
Yeah.
Please go ahead.
Good afternoon. I'll be coming to the last presentation for this session. I'll be talking about a lady with left focal seizures and multiple calcified granuloma. This is a 40-year-old lady who presented with recurrent episodes of abnormal posturing and jerky movements, initially involving the left hand, followed by left lower limb and left side of the face. There's a progressively increased in frequency to once every few minutes over a month, presenting like an epilepsia partialis continua. It was very debilitating. Patient had falls due to the attack. Subsequently, developed also recent memory disturbances and mood disturbances. She was evaluated in a local hospital and diagnosed to have multiple calcified granulomas in the brain and was treated with anti-epileptic medications. However, there was no improvement in the seizure frequency. She presented 4 weeks into illness. That time, vitals were stable, GCS 15/15. There was no cranial nerve abnormalities. Sensory, motor examination were normal. There was no neck stiffness, and other systems were normal. This is MRI, which was showing multiple small discrete T2 hyperintensities, predominantly involving the frontoparietal regions. There was no restriction, there was no diffusion restriction, there was no contrast enhancement. And on SWI, these lesions were blooming.
I'll just stop you here. So over here, this is a very short case, sir. Dr. Elensa and Dr. Natarajan, this is just a very short case. We just wanted to highlight one thing. So when they told about this patient having such frequent seizures, the unusual point was that despite having every few minutes over a period of 1 month, she was having increasing frequency of these jerks on the left side, and she was practically bedbound because of the jerks. She couldn't walk. She would fall if she was walking. And yet the scan, though it was showing these lesions, we were surprised that there was no perilesional edema around it, because that's what we would have expected if we are having almost like a focal status related to a calcified granuloma. So, so this is what led us to look closer at the movements itself. So the next is a video of the lady in the emergency department.
Thank you.
So she had recurrent episodes of the jerky movements involving the left upper limb, left lower limb, face with tonic posturing. So the slow release, like a spasm, and there was awareness was preserved during this event.
So now it becomes much clearer. So now I suppose most people will be able to tell what it is now.
Autoimmune.
Yeah.
In addition.
Yes, sir. Go ahead, sir. Go ahead.
SG1.
That's right, sir. Go ahead. So then we look back at so that's the movement. Very right, sir. So please go ahead, Mithil.
So on a relook at the MRI, there was T2 hyperintensity involving the right caudate and putamen opposite to the side of the jerks. Also
show it, Mithil.
T2
Yes.
Caudate. Flare hyperintensities involving the right caudate and the putamen.
Very subtle. Outside MRI, they had thought it was postictal kind of thing. So it was not, it was not given much importance. It was there. Go ahead.
And putting all this together, new onset focal seizures, stereotypical movements, and subacute memory disturbances with signal changes involving the right basal ganglia clinically fit into a LGI1 autoimmune encephalitis causing a striatal encephalitis. The other differentials we thought of was other autoimmune like SLE causing slightal encephalitis, viral encephalitis, metabolic causes such as hyperglycemia. These are blood parameters, which was showed raised inflammatory markers, the sodium ranging from 130 to 135. Her autoimmune ANA was negative. Other autoimmune parameters panel was negative. Her CSF contents were normal. The viral multiplex PCR was negative. Her serum autoimmune encephalitis panel came positive for LGI1. A PET-CT revealed asymmetric hypermetabolism involving the right caudate and lentiform nucleus, and there was no other hypermetabolic regions in the body. This is a case report timeline, which presented with the left focal dystonic seizures involving the left hand, followed by involvement of the left lower limb and face, with progressive increased frequency, which is very debilitating, resulting in even difficulty in walking and having falls, with memory and mood disturbances, initially treated for NCC, but no improvement in seizure frequency. On a closer look into MRI, noted to have right basal ganglia hyperdensities, PET showing asymmetric hypermetabolism on the right caudate and lentiform nucleus. EEG showed temporal slowing, and serum LGI1 was positive. She was treated with IV pulse steroids, anti-epileptics, and second immunomodulation with IV rituximab. On follow-up, she is found to have reduced frequency of seizures.
60 circle antibody?
ATB was sensor, it was positive, sir.
So is it like NMDAR coming on HSC? Is it something like that, cystic sarcosis and LGI1?
We truly don't know, sir. I don't think there are any case reports on that.
No, but can we postulate that?
It is possible, sir. Very much. NMDA, just like the NMDA can be exposed.
HSV and NMDA.
Yes, sir. Like HSV can, not just HSV, even traumatic brain injury can expose the NMDA. So we can have a secondary NMDA following a previous insult. Is it possible in LGI1?
NCC and LGI1.
Yes, sir. So I don't know about that. But Prabhakar, any ideas, any thoughts? Have you looked at this?
See, I would have expected a perilesional edema. See, the moment you are talking about the exposure of any breakage in the blood-brain barrier can expose the antigens, so that the antigen, any LGI1, any of the antigens can be exposed to predispose for that. But the more interesting point is, generally we have that the calcified lesions with perilesional edema, where certain epitopes are not covered by the body's calcification mechanism and are exposed to the immune system, the epitopes of the dead parasite, which leaks out through the calcification, and that results in the getting exposed to the epitopes are also being characterized and described, if I remember correct. I don't know, Vivek, you must have gone through that. There are few epitopes from the dead parasite released, getting exposed in spite of calcification, which are the cause of perilesional edema in this. Edema. Is this one of this? Is LGI?
We'll have to look at that, sir. I didn't specifically look at this point. Prabhakar, have you looked at this?
One of the things is that previous epidemiological studies in the Vellore district, we found that almost 30% of all normal CT scans had calcified granuloma. So, going by that, possibly could have just been an incidental finding. Especially there was no perilesional edema.
Dr. Prabhakar, I remember the publication from Vellore, that moment the patient throws a seizure, the calcified, there are perilesional edema on the around the calcified lesions, and that was explained based on a few epitopes which are on those calcified lesions have been surgically excised and the epitopes have been characterized. I remember that publication from Vellore.
Yes, sir. Group was looking at it.
But Ellen, sometimes you get only the calcification without any edema, still patient having seizures, right?
That's true, sir. But any patient who presents with the previously known multiple calcification, asymptomatic, who presents with a seizure, they see edema around the calcified lesions. That was the function, the crux of the paper, sir, published paper. They noticed that following a seizure, there are perilesional edema around the calcifications.
If it is without perilesional edema, then that would be a mechanism would be a remote symptomatic.
Yeah, remote. Yeah, correct.
Whereas if it is with perilesional edema and then this perilesional edema is not post-ictal, then it is more likely to be what Ellen sir said about the exposed antigens causing a local reaction and causing a seizure. So it is not truly remote symptomatic.
That is the postulate that it is the antigen reactivation of the antigen causing seizures and edema.
Yes, that's right, sir. So, but in this patient, are these truly are these more extrapyramidal or is it truly seizures? Next slide, Mithun.
So, facial brachial dystonic seizures, pathognomic manifestation for LGI1 encephalitis. However, there's an ongoing debate on the nature. Is it a seizure versus is it a movement disorder? And its origin is whether it's a cortical versus subcortical. So there has been one paper which looked into this. So the points for a paroxysmal movement disorder is extremely short duration. There can be bilateral alternating pattern, phase involvement, and has a poor response to anti-epileptic medications, as seen in our case. There can also be basal ganglia hypermetabolism in PET. The points for seizures is a stereotyped appearance, possible concomitant impairment of awareness, electrophysiological features of cortical myoclonic jerk superimposed with tonic spasm, with a slower activity preceding the facial-brachial dystonic seizures by less than a second, which has been consistently documented in reports. So based on these two, there's a newer network hypothesis. There's a coexistence of isolated facial-brachial dystonic seizures, clear-cut epileptic seizures, and a peculiar mixed paroxysmal phenomenon, along with the neurophysiological neuroimaging findings, suggest a wide cortico-subcortical network, so which involves both thalamus, frontal, and temporal cortex.
Besides the basal ganglia, right? Okay.
Paper by Rajesh Iyer from Coimbatore and Rajesh and Ramkrishnan. This is a paper I know. That
yes, sir. Yes, sir. That's right, sir. That's them. It's very right.
So finally concluding, a recent subacute onset seizures refractory to conventional anti-epileptic medications. Think about autoimmune encephalitis. In our case, MRI finding of right basic ganglia hyperintensity, stereotypical movements of dystonic seizures was suggestive of autoimmune encephalitis, and the calcified granulomas as a red herring in our case. Thank you.
Thank you. Thank you for a wonderful presentation. And
all cases.
Yeah, beautiful, sir. Excellent collection of cases. There is no further messages in the chat box, sir. Any comments from conclusion remarks from Vivek and team?
Only one question, sir. How do you explain it is only on the one side? It is unilateral.
So the LGI1 it tends to be bilateral, but more on one side. So and therefore the features, the imaging features, and some patients will present predominantly with jerks only on one side. Occasional patients can have shifting as well. So, but asymmetry is of clinical presentation is kind of the rule in LGI1, particularly for LGI1.
And imaging also shows unilateral hypertensity.
Yes, sir. It is
changes also on
signal changes
corresponding right side. Yeah.
Yes, you can put that MRI coronal.
So what is the plan for immunosuppression? How long? Rituximab, how long?
So these patients are generally, we are able to stop after a period of 1 to 2 years. It's decided on the clinical follow-up as well as imaging clearance and electrophysiology. So if the patients are doing well in Casper2 and LGI1, we are able to take off the medications. In NMDA, it's a little bit more difficult, but and they need close follow-up because the NMDA tends to remain positive, whereas the VGKC, that is the LGI1 and the Casper2, can come back negative as well later.
Do you straight away go to rituximab from steroid or you try IVIG?
So
this
yes,
patient, it was steroid followed by rituximab. Was IVIG tried?
So for us, IVIG has the same problem of the cost. Steroids was given, and we go with. So the choices over here were actually either the one is that there are multiple factors in the decision. since because of the ease of giving rituximab and now that's much cheaper as well, so it becomes much easier to follow them up. Since she was debilitated, so we didn't go with the milder ones. We see IVIG also as a primary therapy, and pulsed methylpred or pulsed IVIG in the long run can help, but the cost factor becomes difficult to sustain. Whereas rituximab, because if we give 1 or 2 doses, then we can wait almost 6 months before we give the next dose, depending on the CD19 assay. So for that reason, the ease of administration is much more with, because she was fairly debilitated. In previous times, we have used cyclophosphamide as well, which is much cheaper, monthly infusion. But they need to be monitored much more closely for problems.
These are the patients coming with acute illnesses. When you plan rituximab, do you plan any vaccines, at least flu or pneumococcal vaccine or anything you plan before rituximab, or straight away go for rituximab? But do you do a CD19 for every case, or only you do CD19 in follow-up?
So, sir, we don't do a CD19 always before starting, but we do look at the immunoglobulin levels in IgG. We look at that. And when we follow them up, we do the first CD19 assay at 3 months itself, and then see how long. Because some patients might even go on for longer than 6 months before they need the next dose. Regarding the, if it's a very elective plan, like for example, we have rheumatologists who are starting biologicals often have some time in hand, so they usually go ahead. But in our patients who have come to the high dependency or to the casualty or in the ICU, we often start off with the medications and even without the vaccinations. Ideally, if we have time, you're absolutely right, we should be giving them cover them with the pneumococcal vaccine.
Sir,
thank you, sir.
Sir, there is an AI companion in this Zoom. I searched using that AI companion here, used in the Zoom, for LGI encephalitis and neurocystic circus. The AI companion says LGI and neurocystic circus are 2 different conditions. LGI is characterized by limbic inflammation, which can present with this, and tinea solium, the NCC, is an infection of the central nervous system caused by the parasite tinea solium. It can also present as seizures and headaches, but the 2 conditions can have overlapping symptoms, but they are distinct entities. That is what the AI companion of Zoom says about the combination, sir.
Yes, sir. So you should have searched literature for any case reports with both together. So probably it has not found. We also did not find, sir. And what they're mentioning, sir, that is the limbic encephalitis presentation, and this is of course the striatal presentation more than limbic.
So striatal encephalitis may not be the appropriate.
Yes.
What happened to the other areas in FDG PET? Was it only the basal ganglia, or there was some hypermetabolism in the temporal lobes?
It was beyond the basal ganglia as well, sir. They show that picture. Yes, sir. So you can see the temporal lobe also over here is showing. So
yes, sir. Yes, sir.
Okay, sir. Thank you, sir.
Thank you.
Thank you.
Thank you.
If there, sir, I hand over to Professor V. Natarajan, sir, too.
Okay. I thank all the presenters, the team from Christian Medical College, the professors, and Professor Lakshman Narasimhan for conducting the session so very well, and with cryptic comments and his own input of knowledge. And also the participants, particularly Professor Megandan and Chitrambalam, for have posed a lot of discussions, enthused lot of discussions. And finally, I thank the Sun team for arranging all the logistics. Once again, very grateful to all the professors of CMC and the presenters, and to Professor Ellen. Thank you all. Thank you very much.
Thank you, sir. Thank you.
Thank you, Ellen.
Thank you, sir. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you for having us.
It was all excellent cases, and we learned a lot from all those patients and the cases. Thank you.
Thanks a lot, sir. Thanks.
Thank you, Ajit.
Thanks, sir.
Thanks for the CMC punch. CMC punch.
And the Chitrambalam stimulus.
Thank you, sir.
Thank you, sir. See you, sir. Nice.
Thank you all. The Sun team, can we leave? The hosts, can we leave?
Yeah, sure, sir. I think it should be perfect. Thank you.
Everybody's leaving.
Everybody's leaving, sir. We can leave, sir.
Okay, thank you. Thank you very much.
Thank you, sir. See you, sir. Nice.